Welcome to this teaching session at the London Clinic. As Charles was saying, I'm going to be talking on lumps bumps. And for those who don't know anything about this, we were just talking earlier about London Clinic. It's a proper hospital. It's the largest independent private hospital in the country. It has proper wards, a proper ITU, and a full service of clinical specialties, which makes it particularly good for ophthalmology and particularly for oculoplastics. So I work a lot with the oncologists and rheumatologists and plastic surgeons, dermatologists, and so on. And it's nice to be in a proper hospital. It means a lot, and it's been quite an exciting time for the London Clinic. So it's, as you might notice, there have been lots of signs saying London Clinic and Northwestern. London Clinic's gone into a partnership with Northwestern. They're very similar institutions in some ways. They're both charitable, non-for-profit organisations. There's a slight difference that Northwestern has about 5,500 consultants, over 120 clinics throughout Northwestern USA, whilst we have the London Clinic here. But I feel there's a lot the two institutions are going to offer each other and really get the London Clinic on the move. So tonight we talk about lumps and bumps. We'll talk a bit about treatment modalities, then some examples where we want a little bit of audience participation, and lastly a little quiz. Lumps and bumps. What I'd like to do is just tell you the whole talk first. So it's really common sense, mostly pattern recognition, but be aware, the things to be aware of are changes in eyelid architecture, particularly lash loss, eyelid margin involvement, this term unilateral blepharitis. We all know blepharitis, and it should affect both eyes. If it's just affecting one eye, it's a big danger, warning flag. Rapid changes or pain, and also if you're just not sure. So if you're not sure, or you think there's some suspicious signs, then do refer on in. And we're quite lucky at London Clinic. We've got 119 Harley Street, our ophthalmology centre, where we have some 30-something consultants. We cover the whole spectrum of ophthalmology, and particularly for me, we have a one-stop service. You can come in, and then in a half-hour clinic appointment, you can have an incision of a cyst or biopsy of a suspicious lesion, and that's all in the eye clinic. If you need something further, we've got the main hospital where you carry out Mohs surgery and the like, and other major surgery. But we'll come on to that in a minute or two. Fantastic. So firstly, I said we'd talk about some treatment modalities. So if the lesion is benign, then it's fairly simple. You either leave alone or you remove it effectively. So you can leave alone, and you may want to watch and wait if you have some worry that it's something that may change in the future, or you can treat it, excise it, either using laser, and we'll have a little look at that, curettage, cryotherapy, which is freezing therapy, or you can shave the lesion off or excise it. So we'll look at all these things. If the lesion is malignant, then you make sure you completely remove it. So I've put queries next to cryotherapy and radiotherapy because the recurrence rates are slightly more with these, but they're useful for very elderly patients who may not cope with more formal treatments. So the mainstay is excision with histological control of the margins. By that we mean making sure you get the whole thing out and you don't leave a little bit. That can either be done by paraffin section or Mohs surgery, and we'll look at that very shortly. A wide excision, for example, if it's melanoma, and surgeries may be combined with sentinel node biopsy, which we'll look at, and biological agents. So Mohs surgery, this is a way of getting precise it's a removal of a tumour, making sure you get the whole tumour out, but preserving as much healthy tissue as possible. It's particularly useful for BCCs and SCCs, which is basal cell carcinomas and squamous cell carcinomas. These are tumours that grow in a continuous fashion, so they just slowly expand. Whilst lesions like a melanoma, you may get little satellite lesions, so you need to do a wide excision rather than something the more tissue sparing. The high cure rates for Mohs micrographic surgery, it's the gold standard by which other treatments are compared. So this is Frederick Mohs. In the 1950s, he developed Mohs micrographic surgery. So the idea is this. If we have a look at this slide here, you've got a red cancer in the middle, and then you've got a tumour excision, which is the ellipse, or the oval shape, and someone has removed that tumour. But if you look at 12 o'clock and sort of 5 o'clock and 7 o'clock, there are little bits that will have been left behind. So traditionally, you would excise the tumour, you'd send it off to the lab and you may do a what's called frozen section, where you make a couple of incisions, these vertical lines through the mass, and look to see if the edges are clear. But if you're just looking at these points, you'll miss these three little bits remaining. So what Frederick Mohs did is he said, take a slanting excision of the whole lesion, what you think is the whole lesion, then examine the whole cut surface for any tumour. And if you do that, you'll find that the tumour goes to the edges in these 3 points. You then go back and you take another excision until the whole thing is removed. So if we look at that, first of all, on the top right, you scrape down to the bottom of the tumour. Then you take a slanting excision of the lesion. And now in Frederick Mohs' days, you had to inject fixative directly into the lesion and around it, and then cut the lesion out in that manner. But it was very painful. But luckily, a few years later, they developed frozen sections where you can freeze the tissue but still maintain the architecture of the cells. So nowadays, you excise the lesion without the fixative, you squash the cut surface flat and take a little tiny thin slither of the cut surface and examine that. So before you examine it, though, once you've removed it, you mark with some ink so you know where the orientation of the lesion, so you know where to take any further slices. So here we are. You've got your little slither, and you map it out, and they've marked where there's a little remaining lesion, and taken another little ellipse around the edge till you carry on doing that until you've fully removed everything. So that way you remove the whole tumour, you'll certainly remove the whole tumour, you don't remove unnecessary tissue. And that's for basal cell carcinomas and squamous cell carcinomas. For the more malignant lesions, squamous cell carcinoma, melanoma and the like, they metastasize to the regional lymph nodes early. So if you remove a lesion and it's a melanoma or a squamous cell carcinoma, you may want to do a sentinel lymph node biopsy. So you're going to find the lymph nodes where the lesion drains to, see if there's any tumour in those, and if there is, remove all the lymph nodes and do some radiotherapy to try and stop further spread. And to do this, you inject a bit of dye into the lesion and a bit of tracer, radioactive tracer, and a couple of minutes later it'll have gone to the regional lymph node here, or maybe here, depending where the lesion is, and you locate where the lymph node is on under the skin with the radioactivity with a Geiger counter, and then dissect down, and the lymph node would have taken up the stain. So you can see where the lymph node is. Remove the nodes and have a look at them, see if they're positive. Unfortunately, if they are positive, it's poor prognosis and you may need the further treatment. So biologic agents come along in the past 10 plus years, and they have had a bit of a mixed success. So about 10 years ago, basal cell carcinoma, there was great excitement because vismodegib was introduced, and it dramatically shrinks down large basal cell carcinomas. So in the past, if you had a basal cell carcinoma growing into the eye socket, you'd have to remove the whole eye socket and its contents to prevent spread, particularly into the brain. And then vismodegib came in, and it was used to shrink the tumour down, and it seemed to have extremely good results. But over the years, recurrences have been occurring, and you can't really tell where the recurrence is going to come. It might be at the, unfortunately, it's not necessarily where the centre of the tumour was, it might be at the periphery. So, and it's difficult to monitor for these lesions in the eye socket. So the advice has gone back to exenteration. So it's less successful than for basal cell carcinomas, but for squamous cell carcinomas, for a number of them, I've got to get the name right. Cemiplimab is very good indeed, and has really transformed squamous cell carcinoma. And likewise with melanoma, there are a number of biologic agents, and now looking at combinations of agents. So about 30% of melanomas are amenable to biologic agents. So we're going to look at some examples of tumours. Now, we said earlier that you've got to consider whether something's growing fast, whether it's disrupting the architecture of the eyelid, losing lashes, unilateral blepharitis, that sort of thing. So I want you to have a look at the lesions, and if anyone wants to pipe up, that would be really good. You could say, this looks malignant or suspicious or not. So number one, anybody think that looks suspicious? Might be malignant? No, everyone, great. That's, what is that? The xanthelasma. The thing about xanthelasma is that it is important to keep your cholesterol not only at the below the upper limit, but actually well controlled. It's been shown. There's an article about 5 years ago showing that in fact, if you're developing xanthelasma, you've got a higher risk of developing plaques in your coronary arteries and your carotid arteries. So you've really got being, it's okay, my cholesterol is 5.2 or something is not sufficient. You've got to really treat it well. I think a referral to a lipid clinic is probably the appropriate thing. Good. Regarding treatment though, there are a number of different ways. I think excision is the best way. Then you might say you would, wouldn't you? But the thing about other treatments like laser and cryotherapy and TCA peels is they really rely on inflammation causing the immune process within the body to eat up your, the lipid deposits in the skin. And it's a bit of a variable response. For laser, you usually need at least six treatments, which is quite a commitment. And initially, you may find the lesion goes bright yellow and it becomes more visible. But I can understand how people don't want to commit themselves to surgery. But the other thing is recurrence is common, even if you do control your cholesterol. So these little, do they show up? These little things. Any, not milia actually.
Sebaceous acid, please.
Yeah. So syringoma.
Yeah.
And they're actually very easy to treat. You just treat them with some laser. Now, we actually have an argon laser which you could use, but we don't. We're very nice. We're very good. So does this show up? You've got little pot marks on the laser here, and it treats very well, and the skin reepithelializes beautifully, so it's very easy to treat. So now we're on to something else. There's a lesion on the right. The eyelid looks like a sort of stuck-on pigmented plaque of something. Is that benign? Suspicious? Would you worry? It's pigmented. A little bit. Yeah, it's this seborrheic keratosis. There's another picture here, and you can see it's kind of a bit frondy, isn't it? And a little bit pigmented, and it looks like it's just sort of stuck on there. But the lashes, you can just sort of make up. A bit difficult to see, and this is still growing through. And you can just literally shave that off. A little cautery at the bottom to try and stop it coming back. And lashes will grow back, and it'll look great. Now, what about this? So this is pigmented. It's on the eyelid margin. Is that a nasty one, do you think?
So that's great.
Doesn't look great, no. But what does it look like? If it wasn't on the eyelid and it was here, a mole, yeah, that's effectively what it is. So this is it's a acquired nevus. And that's benign. So that's really a sort of pattern recognition thing. Most people want to have them removed anyway, and you would send that off definitely to the lab, but it's benign. It doesn't. If it grows extremely slowly. Aha! There we are. There's one that's not pigmented. Okay, and you can see the lashes are growing. It looks a bit ooky, but you can just clamp it, shave it off with a blade. A little bit of cautery to the base, and lashes will grow back in their normal orientation, and it settles down really very well. So what's this? Is this a nasty? What do you reckon? Yeah, comedones. So it's keratin filled hair follicles, and with those, it's actually quite. It has a little punctum, a little hole in which all the nasty stuff's the other side of it. You just get the smallest needle you can, make a little nick in the punctum, and then squeeze out the nasty stuff. But management, I've put, and this is from a textbook, gentle exfoliation, retinoids, extraction. Really, you just need to 2 cotton buds, little nick, and remove them. What about this one? It's kind of scaly. The lashes are not involved particularly. It's not. Is that suspicious? It looks pretty suspicious to me. Yes, because it's just not right. That's actinic keratosis. It's a sort of sun damaged skin, but it does have a risk of transformation to squamous cell carcinoma, so it's best treated. And around the eyes, there are lots of different treatments for actinic keratosis with 5-FU and the like. All these things are pretty irritant to the eyes, so the best thing to do is cryotherapy, and it's very successful, but you do need to follow the patients up for some while afterwards. So what about this? It's pretty similar, a little bit of patchy, scaly skin, but there's maybe some changes a bit further round. I don't know. So suspicious. Would you just watch it, or would you refer something in? Or?
Does it look like isolating?
Yeah, it does a bit, doesn't it? Yeah. This actually was a squamous cell carcinoma, which involved the whole lower eyelid right out to the lateral canthus. It wiggled its way along. So if you see, it just doesn't look right, and a few lashes lost around about. They've been under an ophthalmologist for many years looking after their glaucoma, but that's the way life goes. And nasty, Not so nasty? What do you think? Sorry? It's a chalazion. Now, a sty is some sort of little abscess on the eyelid, usually the hair follicle. A chalazion is specifically a meibomian gland that's become blocked. Each eyelid's got about 40 meibomian glands, and usually they produce a nice runny olive oil. But sometimes they produce a thick oil and it gets clogged up and blocked. And then all your natural bio that's sitting on your lashes gets in there and causes an infection. You get this. And so the treatment is really you can just do hot compresses and wait, and eventually it will settle down. But it might be 6 months or longer. Or you can make a little nick into the gland and scrape out the gubbins. Now, the question of when, some people say you should wait till it's all settled down. But if you've got a job on the cosmetics counter at Selfridges or something, you probably don't want to do that. So you can incise them straight away. And the other treatment is treat the underlying meibomian glands, because if you've got one, you might get another. So hot compress, that's a proper hot compress you buy from a pharmacy. You put it in a microwave, it warms up, and you lie back with it over your eyes for 8 to 10 minutes. It's got to take time for the heat to get through the skin, muscle and cartilage and get to the glands. That warms up the glands, the oils melt a bit. Don't use a hot flannel because it's too hot and too cold and does nothing. It's been proven that hot compresses work in large multi-center trials. Next thing is omega-3 flaxseed oil, or you can use fish oil if you're masochistic. 2 1-gram capsules a day with meals. Again, they're big capsules. You take them by mouth, they get incorporated into the omega-3 gets into the glands. It's a nice runny oil, and they flow more freely. And then lubricants may help. If you're really having problems with recurrent styes, then low dose antibiotics such as doxycycline or azithromycin or clarithromycin may help. And the other thing is cyclosporin drops have been shown to help in posterior blepharitis, which is Icovez or Restasis in the States. That's an anti-inflammatory. Now, you can't really use steroids long term in the eye, but you can use cyclosporin. This is a patient who came into 119 with a cyst, and this is what you do. We've got no volume, no sound. We've got the sound of issues. How do I get volume? No. So you make a little incision, and then you scrape out all the gubbins with a curette. And you can also inject a tiny bit of dexamethasone steroid to just settle things down. Put a bit of ointment in, or antibiotic ointment. And any ideas? Nasty, not so nasty? Nasty. It does look nasty, doesn't it? So if you've had a chalazion in the past, you may get an immune reaction to it, and then this is called a granuloma. So it's just inflammatory tissue, and usually there's a little tiny stalk at the end, and at the slit lamp you can just put a little proximethicane drop in and snip it with a Vanna scissor and take it off. There we are. There's a little lump down here. Any ideas? Nasty or not? Everyone's intent on saying nasty to everything. This is just it's a little, yes. So this is a little skin tagger. Squamous papilloma. They're often viral related, the HPV virus, and you can just shave them off again, like you saw in that previous where we were shaving off the nevus. Couple of easy ones. That's not nasty. No, that's. Anybody know what it is? It's a cyst of Zeiss, which, because it's all yellowy. it's comes from the sebaceous glands of Zeiss. So it's sebaceous, so it's kind of yellowy. This next one is a cyst of mole, which is from the apocrine sweat glands, and so it's kind of transparent. And these you can just shell out. You make a little tiny incision through the skin on the top, and if it doesn't pop, you can just shove a little thing out. Sometimes they pop, in which case you can just cauterize the base to stop it coming back. So that's a cyst of mole, quite benign. And this is what's this? What's this? So you've got some vessels, some kind of pearliness. That's a basal cell carcinoma, yes. So they have this kind of pearly edge, and they eventually develop a little crater in the middle and tend to bleed. So that is one of the tumours that the Mohs surgery we were talking about is good for, and that the vismodegib is turning out to be less good for. But it has a good prognosis on the whole. Good. There's another one developing a little crater, little ulcer in the middle. They were called rodent ulcers. And there we are. That's further down the line where you got all the lashes have been lost. So you've got that little hole in the centre. They can be pigmented. So this is a pigmenty. You got the pearliness and everything, but there's some pigment in it. And they can be multiple with areas of actinic keratosis and the like. And this is called morphaic, where you don't have that nice distinct edge, and it can grow under the skin rather. And these are particularly, the Mohs surgery is particularly useful for these ones where you can't tell the edge of. So here we've got a sort of similar-ish tumour, but it doesn't have the pearliness really, does it? I mean, it's all a bit sclerosing. So you may think, oh, it might be a morphaic basal cell carcinoma, or it might be a squamous cell carcinoma, which it is. And squamous cell carcinomas tend to go to the lymph nodes earlier and spread earlier. They're more aggressive than a basal cell carcinoma. And this is just the patient we saw before, just to remind you. That was a squamous cell carcinoma as well. So again, Mohs surgery is good for this. They might need a lymph node biopsy. Good. And they've got the 5-year survival rates, and the whole survival is very good for lesions around the eye because you tend to see them. But you can get this sort of situation in immunocompromised patients. So just remember that immunocompromised patients, the skin tumours can be much more evident. So just a quick, malignant or not? Malignant, great. Malignant or not? Probably not. No, that was actually a little tumour of a little schwannoma. This down the bottom, highly malignant. Malignant, yes. Oh, we're getting the idea. And this one, bottom medial, lashes all look fine, don't they? And that was benign as well. But there's no shame from referring anybody in. So you were talking about pigmented lesions. We've looked at quite a few already. We looked at the nevus, kind of mole-like thing, the seborrheic keratosis, the like stuck-on plaque. We've talked about suspicious things that make you suspicious. Well, with pigmented lesions, it's asymmetry, irregular borders, that's asymmetry of pigmentation, colour variation and rapid change. So the malignancies you're considering are melanoma really and pigmented basal cell carcinoma. And management, excision with histology, and then will either be, if it was a BCC, it'd be Mohs. If it was a melanoma, you'd be consider a wide excision. Now, if you get a melanoma on your back, And, the teaching used to be a 10 centimetre radius excision, which obviously you can't do on the face. So you just take as much as you can whilst preserving the eye. So you can take as a unit a lower eyelid or an upper eyelid and then reconstruct. You can't take both so easily, but these are pigmented lesions. They're not really lesions. So what's that? That's just freckles. And what distinguishes a freckle is really that they get darker in the sunlight. They get lighter in wintertime. Obviously, there's no treatment needed, but except you do need factor 50 to stop, because there tend to be patients people with fair skin, so they need good sun protection. We looked at the pigmented nevus, the pigmented basal cell carcinoma. But what's this? This has been there some years. It's not really growing very fast, fairly evenly pigmented. But this was simple lent. It's difficult to tell. But you can either go for a regular follow-up, but I wouldn't. It's so easy to take a little biopsy and send it off. I'd biopsy that. This was simple lentigo, so it doesn't get darker in winter, in summer rather, and lighter in the winter. It's there, but there is no treatments actually needed, but diagnosis. Because I'll tell you why. This patient has had a similar lesion, but they said there'd been a bit of a change recently. And so biopsied that, and that was lentigo maligna, which is a sort of precancerous form of melanoma. Whilst this patient looks fairly similar again, but maybe it's still a bit more uneven and in the pigment. That was a melanoma. And you can see it stretches right along the lower eyelid. So just we've talked really about melanoma and wide excisions, the fact it spreads, and immunotherapy. So just some more pictures of melanoma, just to get it into the brain. It's pattern recognition. You can see that uneven pigmentation. And again, this sort of uneven pigmentation. So anything you're worried about, you really should be biopsied. Now, it's just a couple of more uncommon ones. We talked about unilateral blepharitis. This is obviously suspicious. I need to ask you. We've had tumours from the skin and from the nerves and from the. This is one from the oil glands. This is a sebaceous carcinoma, and they are a bit like melanomas. They tend to spread quite early, and they're quite nasty. So the survival rate, a 5-year survival rate for advanced tumours, 5 years. That's just another sebaceous carcinoma with its unilateral. It's a bit advanced. You'd be hoping to pick things up much more quickly. And this is a tumour of blood vessels. And we don't see it so much, but when I was training, you saw absolutely tons of it. So it's called Kaposi's sarcoma, and it's particularly associated with HIV. But once you get the CD4 count up, they disappear. So it's not seen so much now, luckily. And this. Any idea what all these changes around the eyelids are? It's not eczema. This is sarcoid. Sarcoid can affect all the kind of parts of the eye, from the lids to the conjunctiva, cornea, anterior chamber, and uveal tract and the vessels. And treated with steroids. This patient had this funny hardish lump on the upper eyelid just a couple of weeks, You look at it, you think, oh, the lashes look okay-ish, and maybe it's just a chalazion, but there's not really a chalazion. So that was biopsy. We were up at the Royal Free, and that was a Merkel cell tumour. They're rapidly growing and really quite nasty. Tumours, you usually see them either on the upper eyelid like that or on the brow, particularly common on the brow. But you want to catch them early. So another reason for just, biopsy anything that you're suspicious of. So red flags: destruction of normal eyelid architecture, loss of lashes, unilateral blepharitis, recurrent or non-healing lesions, rapid growth, ulceration, induration, particularly if things are fixed to the underlying tissue. That's a bit worrying. And lymph nodes. That used to be a pass-fail thing in finals, wasn't it? If you examine a lump, you have to examine the lymph node. And if you just examine the lump, you'd be, fail. So I think we will just go through the questions, because this is an important quiz. Firstly, basal cell carcinoma is the most common skin cancer in the periorbital area. Is that true or false? Periorbital area. True. Great. Eyelid melanoma is commonly excised by Mohs surgery. Commonly. A chalazion should not be excised when it's still inflamed. Yes. You can do. Yeah, quite. Antibiotic ointment has been shown to help in the treatment of chalazion. No, you're quite right. Although we all give it. Flaxseed oil capsules have been shown to reduce the severity of posterior blepharitis. Yes. Unilateral blepharitis is common and should be treated conservatively. Though eyelash loss is an indicator of malignancy. Yes. That's our show for today. Thank you.